So, okay, we're recording and it's Tuesday, June 12th. Let's rock and roll through this second the second PowerPoint for Unit 3. We're going to introduce a little bit of special populations and continue our review of kind of general pathophysiology, physical assessment kinds of material that you'll need to know for your comp exam and for your boards, because they really like people to know about preventive medicine and screening for metabolic diseases, which is sort of the biggest, one of the biggest crises facing, in particular, people in Western culture. So we're going to start with just things you have to memorize. This is just stuff you got to memorize. The BMI classes, body mass index. We're not going to ask you to calculate anything, because in the real world you would Google a BMI calculator and they would do that for you. But the CDC, some of those Healthy People 2020, improving health, reducing cardiovascular disease, reducing incidence of diabetes, earlier screening, comprehensive, everybody screened for these things regardless of your specialty. Those are big pushes. So BMI comes up a lot. And the CDC has a bunch of neat charts and growth curve and things like that there are standard BMI numbers. There's generally healthy, there's overweight, then there's obese, then there's degrees of obese. But you can be really, really particular with this by doing BMI by age. And again, online calculators for young girls, young boys, adult women, adult men. It can be very specific. For our purposes, and really for the ANCC's purposes, you just want to be familiar with the ranges. You want to know what BMI is, what are the cutoff ranges. Is someone whose BMI 30, is that good or not? If someone's BMI is 15, is that good or not? Healthy, I should say. And if you would like more information about for kind of nutrition education for patients, Department of Agriculture has dietary guidelines that, based on age and sex and activity level, will tell you exactly how many calories you should have in a day and what your macronutrients ought to be. But these are sources that you can go to in your practice if you want actual, more information for that. And this is just an example of, for boys, getting up to late adolescence, early adulthood, 2 to 20, you can see how, based on age, that BMI varies of what would be considered a healthy range. But you see, appropriate BMI is much lower for younger people than as you age. You wouldn't want to have a BMI of 19 if you were 6, but a BMI of 19 would be on the lower end of healthy for someone who was say 16. It's possible, not on our exam, but on the ANCC exam, that they're going to give you a picture. They'll have a couple of questions that you have to click on a picture, or it'll be a pretend electronic medical record, and you'll have to click on the labs tab and get some information, and then click on maybe their most recent vitals, that kind of thing. So things like this that have charts or visual kind of representations that you might need to make a decision based on your ability to read this, you want to be sure you can understand percentiles. If someone's in the 95th percentile for height, what does that mean? If they're in the 10th percentile for height. So that may that may come into play for y'all. We don't have any questions designed like that for you, but the ANCC might. Continuing just with this concept, again, you want to memorize the normal healthy ranges, those numbers. Ooh, stop it. Those numbers associated with that. This is kind of the super generic BMI chart. Healthy, they say 19 to 24. You may have also seen that it's in half numbers, 18.5 to 24.5. That's healthy. And all those half digits, you're not going to have a question where a 0.5 is going to make a difference. That's way too, because again, these are all specific. This could be made more specific to adult women, adolescent women, young boys, those kinds of things. So generally for adults, these are the ranges you want to know. Under 25 and really 30, BMI over 30, that's sort of the magic number of what's considered obese. And that's where all of the cardiovascular and endocrine complications are pretty well set up, which is why this range here, where they're not healthy but they're not technically obese with a BMI over 30, this is where we want to try to catch and reverse and prevent the complications that come with that. Which brings us to, so yeah, 30, that's your obese. 19, under 25, 19 to 25, healthy. Under 19, you would be concerned why an adult is unable to maintain this healthy range of body weight. And again, these aren't folks. This isn't, our job is to recognize and refer to primary care. We're not going to go digging around if you're working just in a psychiatric capacity for why somebody's underweight or having failure to thrive as an adult. Could be a lot of things. I mean, could be hyperthyroidism, could be an eating disorder, could be some kind of obsession related to exercise or things like that. But anyway, know the ranges. You will be good to go. But for these folks kind of in the middle, folks who are not quite hypertensive, not quite diabetic, not quite, we want to encourage y'all to commit to your memory forever and all time. The metabolic syndromes. Anybody remember? Q&A time. What metabolic syndrome, fasting blood glucose, what that range is? Because it's a range. Any guesses? 110 would fall in the range of metabolic syndrome. What should a normal, healthy, fasting blood glucose, what should it be? Right. You want a fasting blood glucose under 100. So, yes, perfect. So, if it's over 100, but up to what? Because at some point, it becomes indicative of diabetes. Leah nailed it. Right. So, just memorize this. Metabolic syndrome, fasting blood glucose between 100 and 126. Because if you have multiple fastings over 126, that's different. HDL cholesterol, metabolic syndrome for men. So again, this isn't super low, oh my goodness. This is just in the constellation. These 5 things in constellation mean the person is on their way to significant cardiovascular and endocrine disease. So we're trying to catch this syndrome, essentially. So what's the cutoff for men and women of low HDL cholesterol? Yes, thank you, Jennifer. Under 40 for men. It's a little higher for women. 50. Thank you, Cecilia. Nailed it. Absolutely. Absolutely. Triglycerides over what? Not the highest in the world, but over 150. Yes, ma'am. Blood pressure, that's over. Right, exactly. Perfect. Blood pressure, that's over. You know, there was some debate at the on-site about what the blood pressure cutoff was going to be. 130 over 85 is what I see. Because again, 140 or 90 should qualify people for type 1 hypertension. But if they're not quite there, if they're at 130 over 85, they're on their way to having that be their consistent blood pressure. That's not good. So 130 over 85, lower than absolutely, type 1, absolutely type 2 hypertension. Gosh, side note, I remember working in the ER one day and there were 2 patients who came in, and it was, I'd never seen a diastolic of 200 until that day. And they were asymptomatic. It was wild. So that totally different, unrelated. Our body's ability to compensate temporarily for a system going wrong is phenomenal. So yeah, 130 over 85. If it's higher than that, you're worried. Starting to get worried. And last but not least, and we'll wrap it up. Waist circumference, men and women, a waist circumference over something and something. Men is 1, women is 1. That's right. 40 inches and 35 inches. Yes, ma'am. And I will say I have never personally gotten a tape measure out to measure anybody's waist in the office. I'm not going to discourage y'all necessarily from doing that, but kind of the point of metabolic syndrome is these 5. We have 2 3s, but that should be 1 2 3 4 5. Essentially being in between healthy and unhealthy, if it's in all of these areas, does not bode well for folks. And that's why you want to check. We'll talk about monitoring for folks, because you may be, some people don't like going to the doctor. They don't have a primary doctor. You may be the person that they see. Cecilia's asking if it's 3 out of the 5 or all of the 5. And Cecilia, I will say that's a good question that I don't have an answer for you right now. But I will. Because at this point, I don't know. So let me see. Or you may be able to find it, kind of if you want to Google that while we're sitting here. One of the guidelines that is 3 out of 5. It might be, to be honest, I don't know. So I'll find out for you and for everybody. So these are the 5, 1 2 3 4 5 markers that in combination, if it's just one and everything else is fine, then no, that's absolutely not metabolic syndrome. 3 out of 5, great. I would believe Kaplan and Sadix. I would believe them if they say it's 3 out of 5. So, if you're seeing somebody and you get labs done because you see them, they don't have a regular doctor, so you order it for them on an annual basis. Or if you're seeing them you have them on a medication that you want to check at every 6. You're just trying to see how many of these are kind of light up. I have folks that I really have to encourage to go to primary care surprisingly often because of changes that we can track when we track it. There's nothing wrong if these folks aren't seeing primary care for you to order lab work annually. It's really the smartest thing for you to do if you're writing medicines for them. And you're trying to see what is psychiatric and what is organic and physically based. So these are the things, and if you just memorize them, you can catch them, direct the person to primary care, to a nutritionist. You can absolutely do all those things. So we're going to talk about, I'm sure we talk about metabolic syndrome, and what class of medications comes to mind immediately. You don't even have to read it off the slide. Unfortunately, yeah, absolutely. Absolutely. And I guess atypicals are kind of the poster child for drugs that can cause metabolic syndrome because they just so happen to affect a lot of different pathways that can cause altered insulin sensitivity, increased feeding behavior, reduced awareness of, hey, I'm full. So when you look at these, we included some receptor activity, and you'll think, oh my goodness, that's what all of them do, pretty much. And some of them do it worse than others. So 5-HT2A agonism, 5-HT2A blockade. And remember, 5-HT, that just means serotonin. 2A means specifically the serotonin receptor. And serotonin 2A receptors are really, really important in the insulin release process. You don't just have serotonin 2A receptors in your brain. You have serotonin 2A receptors all over your body. And right, tons of serotonin receptors in your gut. Absolutely. But here's the thing, is serotonin 2A receptors in particular are involved in the release of signals to try to say, hey, go eat. Feeding behavior. In the literature, they talk a lot about satiety, feeding behaviors. And the problem is, if you block a lot of serotonin 2A receptors in particular, so if you're agonizing serotonin 2A receptors, then what you may end up with is a downregulation. Remember, if you flood a receptor, the brain might say, oh, I don't need as much of this receptor, I have too much signaling. So some drugs, if they do 5-HT2A agonism, you may end up with a downregulation of those receptors. So if you're also blocking them, you administer a drug that can block that, then you have fewer receptors that are then being blocked. So the signaling is further disrupted. Blocking 2A, serotonin 2A, that's going to cause an increase in secretion of these pro-eating kind of peptides and chemicals. And that's really what you see for folks, the behavior that you can see for people who were taking drugs that block serotonin 2A, which is how all of our atypicals are atypical. So you have this altered feeding, the brain becomes more sensitive to signals saying I need to eat. And you have an increase in feeding behavior. In the it's not just the brain that you have these receptors. What's interesting is you have serotonin 2A receptors on skeletal muscle, and when those guys get activated, serotonin lands on them, that cues the muscle to increase uptake of glucose. So you got extra blood sugar floating around in the bloodstream. You want it to go into skeletal muscle to replenish the glycogen, get it out of systemic circulation. Blood sugar goes down. That's a good thing. But if someone's taken antipsychotics and those receptors are blocked, that's going to impair your muscle's ability to pull glucose into them. And you're going to end up with, just extra glucose floating around the system, trying to cue the pancreas to release even more insulin to get it out of there, but you're blocking one of the mechanisms that draws it into muscle. So that's a problem. With histamine in particular, and a lot of drugs, if they're sedating, there's a good chance they have antihistaminic properties. Histamine is an alertness promoting neurotransmitter. When people get alert, they're less likely to want to feed. You think kind of folks are either in the fight or flight kind of active mode, or they're in the rest and digest mode. So typically things that promote alertness do not promote rest and digest functions. If you're on a drug that's blocking histamine, well, you're making it hard for your body to suppress the feeding behavior again. Because if histamine says don't eat and you're blocking histamine, the body will pursue feeding. This M3, that means muscarinic acetylcholine receptors. You think acetylcholine, we think, cognition and those kinds of things. The can't see, can't pee, those kinds of symptoms. We have a lot of acetylcholine, this M3 receptor, a lot of those that are actually on the pancreas. And this is one of the ways that when blood sugar starts elevating, rest and digest function, okay, let's get some acetylcholine transmission happening. Let's promote release of insulin. Let's get some of that glucose out of circulation and into the tissues where we need it. If you're blocking these receptors with a drug, then you're interfering with the pathway that your body's trying to use to get insulin released. What's really interesting too is that studies are and a lot of this is with other mammals, mice and things, but this signaling, this M3 system for signaling the pancreas to release insulin in the presence of high blood sugar seems to only work in a healthy blood sugar range, that once sugars are elevated, this doesn't seem to work as well. And for someone who maybe has metabolic syndrome, someone whose blood sugar is elevated because of other problems caused by other pathways that have been impacted, you're essentially having the person maintain really high blood sugar levels. You've impaired two different means to try to manage it. One, the 2A blockade, it's not getting into muscle cells, so blood sugar staying elevated, which now means this pathway, this acetylcholine pathway, that's not able to cue insulin to get released to help either. And that's really what we see. These drugs, clozapine, olanzapine, quetiapine, are the worst. They're the pits. They're most likely to cause metabolic syndrome. And if you Google olanzapine receptor profile, it'll show you that it blocks 5-HT2A, sure. It's really antihistaminic. It's really antimuscarinic. So it's essentially all of those all of those pathways that we listed here, these 3 drugs do worse than the others. So it's no surprise that folks on those medicines end up with high blood sugar, and their lipids elevate, their weight elevates, their blood pressure goes up. Kind of a perfect storm. The research also shows that if a drug is only, say it's only really bad antihistaminic, but it's not so, it doesn't have as high affinity for those others, that it doesn't cause the weight gain as bad. It's really like your body has some backup plans to manage problems. But if you take all of those out of the question, then the body can't compensate anymore. Even at low doses, because quetiapine has such high affinity for those other receptors, for the muscarinic, the histaminic, the not D2 receptors, which you have to get higher doses of quetiapine to really saturate the D2 receptors, but it's still really active at these weight, what we call them, kind of metabolically relevant receptors, even at low doses. So there's risk of, even if you have somebody on 50 to 100 milligrams, say it's just for sleep because that's the best option they have. That's the problem. And clozaril probably has the highest affinity on those receptors of any of these. So for people who you're starting atypicals, this isn't new. This is just stuff to memorize of the monitoring that you do before you start. And then after you start, you probably want to check them again in 3 months. And if they're stable, if levels haven't gone up in 3 to 6 months, then you can bump to annual. Do people continue to gain weight, or does it plateau? That's a really good question. That is a good question. What the other things that you'll read about, if you read through articles on this, is that there's a certain kind of subset of people who are likely to have this extreme weight gain with atypicals. Not everybody that you start on an atypical is going to gain a bunch of weight and become, dealing with blood sugar issues, and they need a statin and all these things. Not everybody will, but there's certain genetic, I'll try to find that article. There's a certain genetic profile of folks. Gene side. Maybe they'll tell us. Shoot, but no, you say that, and there is a particular, they have isolated a gene that is highly correlated with people who put on ridiculous amounts of weight and develop really bad insulin insensitivity. So, and what they tend to find is that folks who were underweight before they started, underweight or lower weight, may be at higher risk for this response. That doesn't answer the which gene is at question, but we don't want to think, oh, this person's a healthy weight, I'll start you on antipsychotic, I don't have to worry as much. They may be at the highest risk to develop these, lipid, glucose abnormalities. It's really interesting. Interesting stuff. So main thing, know your BMI numbers, know your metabolic syndrome ranges for testing purposes and for in real life practice. And those receptors, M3 muscarinic, antihistaminic, just keep an eye on the meds that you write if they act on those receptors too, because those patients are just going to be at greater risk and may need more education about diet and things, and may need closer monitoring. track their weight a little closer. So a different population of people who have a medical condition that will require us to change the way we monitor and the way that we prescribe. And this was a pretty big change in the last couple of years, was the pregnancy and lactation labeling rule. There used to be these categories. You'll still see them used, but the way that the FDA wants to communicate risk to pregnant and lactating women and children has changed. And it's much less prescriptive, do this, don't do that, and they really encourage us to have a conversation with patients about the risks and benefits of medications. I'm sure I'm speaking for Dr. Fogger when I say we strongly encourage you to work collaboratively with a either pharmacist. I recommend talking to pharmacists, but to work with, if you're working with a pregnant mom, with the OB, and then after delivery with the pediatrician. These are not decisions you want to make on your own. You want a lot of information going into prescribing decisions with patients who are pregnant or lactating. So don't do this on your own. You can consult with your collaborator if you live in a state with those, but be on the same team with the OB, with the pediatrician, a pharmacist, right? And document that you have consulted with these folks. You've explained the risks and benefits to the patient. They voice understanding. They agree to proceed with blah, blah, blah. Because this is an issue where, sure, and the options. Because this is certainly an area for that liability and malpractice can come into place. Mainly because you're thinking how emotionally charged all of this is. This is really important decisions to try to guide patients through. So and this is every drug label that the FDA releases is going to have Section 8, and that's always, it's in the special population section for pregnancy, lactation, and is any of this going to affect, could this affect fertility? Does taking this medication mean you should be on birth control because of risks to early gestational fetus? Also, potentially, is this drug going to interact with, could they possibly interact with different types of contraception?
Winston's iPad and Deborah E. Jonas MacBook PR.
Oops. Hey. All right. Thank you, ma'am. So yeah, this is available to all people at all times for every drug. So that it's not just, oh, this is category B, this is category X. It's because they really want providers to have conversations about risks, benefits of treatment, the risk benefits of non-treatment. Because no medicine is always an option. There just may be, where'd that come from? Oh, sorry. I guess I skipped that one. And these are all things that this information is based on. There is a registry of kind of accidental exposures, women who didn't know that they were pregnant, who continued a medication. The OB would encourage the person, make sure that information gets sent to the database so they can track. A lot of the data we have is not from actual studies. It's all after the fact. Well, what happened when there was an accidental exposure or an unintentional exposure? And they'll tell you relative risk of some sort of congenital malformation versus what's the normal risk in the population. And then was this generated from, post-chart reviews? Was it randomized clinical trial? Was it based on mice and rabbits or people? tons of information in those things that are really interesting. I strongly encourage you, if there's a drug that you really, really like to use, or a drug that you just want to know more about, to Google FDA sertraline FDA label, for example.
Simone, last semester I thought it was just a horrible experience with a
Oh
young
no.
lady. A young lady was court ordered to take her medications because she had tried to commit murder and a lot of other crimes. So she was court ordered and she got a pregnancy. So
Wow.
she got pregnant and
Yeah.
she wanted to refuse the medications. And the clinicians in her team were fighting to make her, force her to take her, to
Wow.
keep taking the medications. And then she had a miscarriage, and they felt like just for the first, stop it, and then you can restart it. But she did eventually have a miscarriage, and the whole situation was just horrible because then her husband eventually just left her after she miscarried. But they really felt like her risk of not taking her medications were too large. They did not. Her risk were bigger than her benefits, I guess, of not taking it.
Yeah,
Would you say that's wrong?
yeah, you make a really good point. There's a risk to not treating. Drugs have side effects, sure, but there's a risk to not treating people. In particular, moms with depression, they will find different levels of circulating neurotransmitters or metabolites thereof, in babies of moms who were depressed. And they'll find different, I don't know who does these studies, I don't do these studies, but actual brain structural differences in infants and babies born to moms with depression than not. So there is a risk to not treating. There's also the risk of pregnant mom isn't depressed. Well, then maybe she uses substances to deal with it. She doesn't take good care of herself. She doesn't do nutrition. She doesn't do the scheduled appointments for checks along the way. Mom's depressed, baby's born. There's problems with attachment, with neglect. Child isn't cared for well. Those are really bad too. Those are really bad. So this, and they're avoidable is the other thing. We just picked Zoloft just for an example. There are some medicines that tend to be, you can talk to pharmacists, you can talk to OBs. They'll say, yeah, that would be a better one to pick if you have to treat with something. That for Zoloft, and this is what you'll find if you look through this. I don't know if you can see right here, but the links are in the PowerPoint. That overall available studies of pregnant women exposed to Zoloft in the first trimester suggest no major birth defect risk compared to what's present in the population anyway. So essentially, Zoloft in the first trimester, for women who just so happen to be exposed to it, maybe they didn't know they were pregnant, no significant difference. No significant difference. Exposed early on. They do find that later on, third trimester, that is different. So if you have a woman who's pregnant, say she's on Paxil is one that you do not want. And I think, oh, that's on the screen. Okay, good. Whew. It's going to pull up. So this is, overall risk summary. Overall, it's about the same. Not too bad. Exposed early. You can cruise on down and they'll show, but they do find that if exposed to Zoloft later in pregnancy may be associated with some respiratory risks. And so early on, Zoloft might be a good choice. Later on, you may just want to discontinue. Versus if we look at Paxil, studies have shown, not randomized control trials, but just looking after the fact, infants exposed to Paxil in the first trimester have an increased risk of heart defects, like essentially double the risk of, and they talk about ventral septal defects and atrial septal defects, significant heart cardiac anomalies, that some that require surgery, some that don't. But you can see how this reads differently, that there's no reason to have a woman on Paxil when at this time during the pregnancy, when you have an alternative that doesn't convey that same risk to the fetus. And that's the kind of things you put in your documentation that you would discuss with pharmacist, with the OB, with maybe psychiatrists who just happen to work with a bunch of women who are pregnant. So this is the kind of information that you'll get. But Paxil is a no-no for, boy, it would be hard for you to justify a medication with known risk when there's options that don't convey the same risk. Here's just another example. Cymbalta, talking about nursing mothers, because that's another issue, is that, and this is just telling you that Cymbalta is excreted into the milk of lactating women, and the estimated infant daily dose is 1/7 the maternal dose. So this might not be the best drug if you have a mom who's delivered and she wants to breastfeed, because and different drugs are transmitted to breast milk at different rates. So how would you discontinue Paxil with a pregnant woman? If it were me, after I consulted with a pediatrician, an OB, and a pharmacist, I would say, we need to switch you to something else, is what I would do. If the woman is, let's say she has a history of significant depression, maybe this isn't even the first time she's gotten pregnant. If she deteriorates significantly, if not being treated, then I would say we got to switch you to something else. And that's what you do. Because ideally you would say, well, let's just take you off of everything. But if this person has a history of recurrent MDD, moderate to severe, then it's for the best interest of the mom and the fetus and the eventual baby that she be treated. So you switch. And those are the only examples, but I know Prozac has such a tremendously long half-life. Wouldn't be bad if mom was on it before she got pregnant. Because what seems to be the case is that there's a lot of complications in the third trimester when exposed to SSRIs and SNRIs. So if mom was on Prozac and you discontinued at the start of the third trimester, that it would maintain a more significant blood level that would just gradually be on its way out. That's another option that a lot of people will use. It's not ideal. It's never ideal. So you do make the best decision you can collaboratively and document, like Dr. Fogger said. And ask mom what are your plans for breastfeeding? Because say mom says, I have no interest in breastfeeding, then you don't have to worry about drug in breast milk. If mom says, well, I do want to breastfeed, then you would try to pick one that maybe is less transmitted into breast milk. Latuda is the safest one, they say. What used to be considered category B. Has not been shown to have any negative outcome to baby. So yeah, so to what Dr. Fogger and Jean are talking about right here is, if assume patients are pregnant unless proven otherwise. There was a question on that last test. The little girl in the baggy outfit. You need to be sure she's not pregnant because she hadn't had a period in 3 months. But you can, women of childbearing age, you can say, hey, I'll start this medicine, but you need to get a pregnancy test. And you don't want to get pregnant if you're on this medicine. What are your plans for contraception? Contact me if you get pregnant, because we need to talk about what to do with the medications. So yeah, those are kind of ANCC kind of questions too, sort of that anticipatory guidance, thinking ahead, having liability in mind. So section 8 of these drugs, of these drug labels. So the main ones, a lot of mood stabilizers are really teratogenic. Lithium, Depakote in particular. Yeah, Depakote, like Sabina's saying. So thankfully there are, Latuda as a mood stabilizing option, other antipsychotics. Some are better than others, but just mainly take home point. Depakote, lithium, Paxil, Those are drugs that we know there's going to be a neurological or cardiac really negative outcome. The odds are much better. That's not to say every child born to a mom who took Paxil or every child born to a, but what you have is 2 and 3 and 4 times the risk of these problems, and you can't justify that if you have another option. And that's why you want to talk about what are your plans for contraception, because of the way that medications can reduce the effectiveness of birth control. Yeah, Leah, I'm gonna pull up Lamictal's. I won't do it right now, but I'll pull up the new FDA label. I know we want to be cautious with all the mood stabilizers. Some are worse than others, so before I speak to in any sort of length about Lamictal, I don't want to lump that in the absolute no-no group yet, but it may have to go there. So I'm gonna look up that label, and I can email you with it. For some reason, that's not. I just need to look it up again, because for some reason right now that's not ringing the X bell, but I will know for sure. So, mood disorders post-pregnancy, kind of peri-pregnancy, because this is another special population. We can finish this up in 5 minutes. Mood disorders associated with the reproductive cycle. Probably most women after pregnancy have some form of baby blues, which, well, your hormone levels have plummeted post-pregnancy and are trying to establish a new baseline. So upwards of 3/4, if not more, of moms who deliver are going to have some distinct period within a couple of weeks that they're kind of moody, they feel overwhelmed, they might have tearful spells beyond what is normal, their baseline, but it doesn't mean that they meet criteria for a major depressive episode. So SATIC gives you a great little chart distinguishing baby blues, which is real short term, resolves on its own in a couple of weeks. This is a pretty significant life event, so give them a break. Give them a break. But if it continues and continues and continues, then it may actually meet criteria for major depressive disorder, a major depressive episode with peripartum onset. It used to be called postpartum depression. But what we find, come on now, Oh, I see what the problem is. So sorry. There we go. So MDD with peripartum onset, the emphasis is on, these are going to be women who they meet criteria, so 2 weeks solid meeting criteria for a major depressive episode, but there tends to be a bigger emphasis on sleep disturbance, not because of baby waking up every hour or so, but sleep disturbance is real prominent in this presentation. Anxiety is really prominent in a major depressive episode with onset pre or post delivery, and a lot of guilt, a lot of self-doubt, negative self-evaluation, kind of beyond what is reasonable. This is different from, oh, I'm a first-time mom and I don't know, this is so overwhelming, I don't know what I'm doing. This is that kind of almost like a pathological, almost delusional intensity, guilt, failure, there's a problem, can't do enough, that can't be discouraged, that can't be opposed by other reasonable people. Because that whole, guilt, worthlessness, that criteria is very distinct to a major depressive episode. You don't see that. That's not a GAD criteria. That's not a panic criteria. That's certainly not a bipolar or a schizophrenia criteria. But that's real prominent here. So when you think sleep anxiety and sort of this really intense negative self-evaluation, you think serotonin has gone off the rails for sure. So based on animal studies, Lamictal may cause fetal harm. That's helpful, Carmen. I'm gonna, and like I said, I want to look at that for my own edification as well. Did they happen to list one of the letters? If you happen to see in there that they list a BCD letter with it, because the labels may still do that, even though that's not kind of the only way they distinguish risk and safety. Because that may still be what they used to call a category C. May cause harm, but kind of an epidemiological human studies it didn't. And that makes it one that you can probably still justify if needed, because your other options are so crummy. So guilt, anxiety, big thing. And the criteria are met. The DSM-5 wants criteria to be met within 4 weeks of a major depressive episode, but there is debate if that's enough time. Upwards of 10% of women will meet criteria for a major depressive episode with peripartum onset. What's interesting is half of these, the symptoms started before delivery, which is why they don't call it postpartum anymore, because half the time it starts before the child is even delivered. Comorbid severe anxiety, a lot of worry. That obsessive worry, that's a serotonin issue. So that's just general MDD, peripartum onset. The problem that you can have is when it becomes severe with psychotic features, and these are the real tragic cases when after delivery the mom may become delusional. She may be convinced that there's something wrong with the baby, that the baby is sick, that the baby's not hers, that she's not the mother, this isn't my baby. The concern being if those symptoms of psychosis elevate from just disorganized, kind of unusual behavior and thinking to command hallucinations. Kelly's talking about, that's the big concern, is that if you notice a mom who is becoming, and family, things that family and friends can help alert to. What starts off as bizarre, disorganized, turns into delusional thinking, turns into command hallucinations. Category C for Lamictal. Thank you, Karen. Yeah, so that really makes it justifiable, potentially risky. Potentially risky, but not category X, that the benefits may outweigh the risks. Good chance that they'll outweigh the risk, as opposed to, it's all about risk stratification. So you would do that before you did, if you had to. Depakote's going to be down the list. Lithium will be not as far down, but not your best option. But a client who postpartum psychosis, inpatient for 6 weeks, home on Invega, back yesterday. That's interesting that they put her on Invega because she was having homicidal ideation and command hallucinations, which is really, that's the concern. A mom who drowned her children, that's kind of what we think of when we think of this. So all the more reason to screen, and a lot of this is the OB's job, but we can spread the word as best we can about the importance of screening for depression. It's horrible, because that was treatable. That was preventable. Come back. And that's why treating moms for depression when they're pregnant is the safest thing, because depression, and then depression that results in psychosis, is tragic. So you want to be really responsible and very cautious and seek help and consultation when you're writing medicines for pregnant women. But it doesn't mean you just don't treat because it's dangerous. Yeah, Kelly, and to your point, that's why I'm kind of interested in them doing Invega, is that women who develop postpartum, and I think Sadek may have mentioned this, the DSM-5 text mentions this in this section as well, that if the depression started before delivery, there's a better chance that it's unipolar depression, whereas if the symptoms start after delivery, mom's fine, ooh, and then this depression with psychosis begins, it's more likely to be a bipolar, the presentation of bipolar than not, than unipolar. So that's really interesting. So, Invega's kind of a neat drug. I mean, Consta is too, and all those, but Invega has the indication for schizoaffective disorder. Not that this patient had that, but schizoaffective is sometimes when you kind of can't tell if the psychosis came before the mood symptoms, or if the mood symptoms came before the psychosis, and it's actually bipolar. Because that may just mean that just an SSRI isn't going to get you where you need to go. You may want to treat just with an antipsychotic until that resolves, and then see what remains. And another thing too is a lot of times these sort of mixed feature depressions that have a lot of agitation, or a lot of irritability, or a lot of anxiety with them, be on the lookout that this is actually bipolar disorder, which again is a lot of how we describe this. It's kind of an anxious, restless, can't sleep, I don't have a bunch of energy, but I just feel bad, and I'm ruminative, and things are so horrible, and I'm a bad mom, and there's something wrong with my baby, and now there's something wrong with me, and that's, be alert that this may require treatment with an antipsychotic and mood stabilizer. So kind of keep an eye on, did this start before or after? Risk factors for MDD with peripartum onset are not going to surprise you. It's people with a family history of a mood disorder, in particular bipolar disorder. Someone who had a prior episode of depression, someone, it's their first child, there was some traumatic complication with the delivery, they perceive it as stressful, they perceive financial stress, some kind of stress, intimate partner violence preceding the delivery, but mainly the kind of family history you'd always take: mom, dad, brother, sister. Ever have a mood problem? Have you ever had a mood disorder? And the thing that's interesting too about peripartum with psychosis is that 2/3 of these women have another psychotic episode, mood with psychosis episode, within a year after delivery. So this is just a real high risk time for these women. So, kind of be on the lookout that this might be bipolar depression that could actually be from bipolar disorder. And then you want to follow them pretty close after, knowing there's a chance that they will have this again. But again, that's 1 out of every 1,000 live births. So this is not a very common thing, but it's about 1 out of every 1,000 live births. Mom will end up with this peripartum mood disorder with psychosis. And if 10% of women get it, then that's 1 out of every 100 women who have peripartum onset of depression. 1 out of every 100 of those are going to end up severe with psychosis. Jessica is saying that you'd had a patient with peripartum depression too. There's a screening instrument. There's actually the Edinburgh postpartum depression screen. Get on there, little doggy. I think I wrote it down. Yeah, the Edinburgh postpartum depression scale. The American College of Obstetricians and Gynecologists recommend screening moms for depression during pregnancy and within a year after. So they're recognizing there's kind of a 1-year high risk window of mood symptoms returning. The Beck depression's fine. Any kind of formal screen. PHQ, Beck depression, there is a specific one of those. Very interesting. Not common, but it happens. But 1 out of 10 women are going to meet for major depressive disorder. That's worked in labor and delivery, and patient pregnant had a court order that when she delivered, she could not. Yeah, yeah, because depression is really treatable. It's really easy to screen for it. There's a lot of available treatments out there. We need to do the best we can to ask moms and couples and about contraception. Do y'all plan on having kids? Birth control measures. Make best medication decisions. Screen for depression and anxiety. Substance use, of course, and afterwards as well, because this we can really do. We can intervene in a lot of ways. Last but not least, PMDD. The DSM-5 made it official. This is like PMS, but official. That it is a predictable, consistent fluctuation of mood, symptoms, irritability, anger, sadness, anxiety, that 1 out of every 12, 13, 14 women experience. That's a good, this is way higher percentage than MDD in the population. And this is a lot. 8%? That's a lot. So you may work with women who kind of regularly, on about a monthly basis, they have a constellation of symptoms that is distressing to them, can affect relationships, can affect work, and then it resolves. It's always preceding menses and then resolves within 1 week. I think I've worked with, when I was out at Childersburg, I worked with a couple of women who met criteria for this. This was the main thing that brought them into treatment because of how it affected relationships and work, and they were just miserable for about a week every month. So again, can't be explained by substances. They don't meet criteria for MDD, meaning it doesn't last outside of this kind of cyclical presentation. And actually, Prozac has an indication for this, and it has been really helpful for the folks that I work with. So this is not considered a severe mental illness, but this may be all or partially a reason why women of childbearing age would come to see you. And we can offer, CBT kind of worksheets, CBT exercises, but you got a medicine option too. So all that being said, really good questions and good contributions from y'all. I appreciate the double checking the metabolic syndrome thing and menopausal dysphoria. Sabina, I don't know. I think they would just. My suspicion is that because 8% of this affects 8% of people, it can't be ignored or completely dismissed, and it doesn't meet severity criteria or duration of MDD. But to draw attention to the impact that this can have on people's lives. Now, is this eventually going to be changed to some kind of mood disorder due to a medical condition, or mood disorder due to, I don't know, fluctuating hormone levels? Because that would be my guess. And I have certain theories about why some disorders get a lot of attention and some don't. One final point I will say, any women with whom you work who meet criteria for borderline personality disorder and or bipolar disorder, try to keep track of how many of those women have significant reproductive system problems. I say this all the time, like endometriosis, difficulty getting pregnant, miscarriages, had a hysterectomy before age 40. I mean, like young. Just pay attention, because I would say 95% of women I've worked with a cluster B personality disorder or some kind of bipolar mood disorder or unspecified have. So this is much more physical. I think it starts not necessarily in our brain, for women at least. But anyway, way beside the point. Any last minute questions? We posted an extra PowerPoint to kind of cover the sleep medicines in the sleep chapter, or little readings. Look over that. That should be real to the point. And a study guide to help y'all prepare. But any last minute questions before we shut it down? So after this, it's review time. Yep, I'm going to come up with some suggestions on how to take different chunks of topics for your board vitals, if you got the board vitals, which I hope everybody did. And we're going to hit roles. We're hitting research, we're hitting scope, we're going to town. It's going to be a good time. Good time. Hypersomnia. Ooh. Yeah, that just sounds awful. Folks who will kind of like just go into REM sleep, just out of nowhere. Whew. Yeah, what we hope about Board Vitals is to help kind of review as you go through the questions, because every question can be kind of informative, but also just get practice taking the questions. Just practice staring at their questions. All right, everybody. Thanks so much for your contributions tonight. Have a good night, and let us know if you have any questions. We'll see you then.